Right, let's get straight into it. We're looking at a pretty sophisticated approach to predict if a patient is likely to end up back in the hospital within censure days of being discharged. This isn't just about crunching numbers, it's about using the rich, detailed stories told by electronic health records to spot trouble before it happens. So, why are we even bothering with this? Well, imagine the hospital system as a giant complex machine. When patients get readmitted so quickly, it's like the machine is overheating and breaking down repeatedly. It costs a fortune, patients suffer more, and doctors and nurses are stretched thin. Now, the old ways of predicting this risk? Think of them as trying to understand a movie by only looking at the first frame. They use static scores or basic info like age and gender, but a patient's health after leaving the hospital is constantly changing. Their vitals fluctuate, their medications change, their condition evolves. That's where EHRs come in. These digital records are like the full script of a patient's journey, packed with vital signs, lab results, medication lists, and past hospital visits over time. The real challenge is untangling this complex, ever-changing story to find the signals that scream danger ahead, without getting lost in the noise and ensuring the system we build is actually useful and fair for doctors. Okay, so what's the big idea here? Instead of just looking at one snapshot, we need a system that understands the story unfolding over time. Our goal is to build a machine learning model that reads these EHR stories longitudinally, meaning it tracks how a patient's health changes day by day, week by week, leading up to discharge. This temporal awareness is key. But building such a model isn't enough. Doctors won't trust a black box that spits out predictions without explaining why. So, another crucial part is making the model interpretable, giving clinicians insights into what factors the model is considering. Finally, this isn't just an academic exercise. We need to make sure this thing works in the messy reality of hospitals, respects patient privacy, doesn't unfairly disadvantage certain groups, and can actually fit into how doctors already work. That's the whole package we're aiming for. Alright, let's talk about gathering the raw material, the data. We went deep into the hospital's EHR system, pulling out information from over 5 years, 2018to 2023. We focused on adults who had been hospitalized before because, let's face it, if someone has a history of hospital stays, they might be more complex cases. We also had to be careful. We excluded patients with terminal diagnoses, hospice, palliative care, because predicting readmission for them isn't the same goal. And we threw out records where too much data was missing, especially vital signs, labs, and meds in the critical period right before discharge. Think of it as needing enough evidence to make a reasonable judgment. What did we end up with? A solid dataset of over 42,000 patient discharges. For each patient, we collected everything, basic info like age and gender, their vital signs and lab results over time, what medications they were on, their discharge summary, and, importantly, whether they were readmitted within censure days. We defined readmission very clearly, any unplanned return to the hospital within that window. And of course, all personal identifying information was stripped out following strict HIPAA rules, protecting patient privacy. Now, raw EHR data is rarely clean and tidy. Think of it like finding a treasure chest full of gold coins, but also some empty pockets, some coins that look suspiciously heavy, and maybe some coins stamped with weird symbols. First, we tackle the empty pockets, the missing values. For numbers like blood pressure or heart rate, we used the median value, the middle number when all values are lined up, as a sensible guess for what was missing. For categories like race or insurance type, we used the mode, the most common category, as the placeholder. If a lot of data was missing for a specific category, say over %, we actually created a new category called missing. Sometimes, the fact that the data is missing itself tells us something important. Next, the weirdly heavy coins, the outliers. We didn't just throw them out. We used Winsorization, which is a fancy way of saying we capped the extreme values. For example, if someone's systolic blood pressure reading was ridiculously high, like Sambay mmHg, we'd treat it as if it was Lambay Wuxi mmHg, the Jirshajoth percentile. This keeps wild measurement errors from messing things up, while still allowing truly extreme but valid readings to count. Finally, instead of looking at single snapshots, we looked at trends. We calculated averages and variability over rolling T-day periods leading up to discharge. This helps capture if someone's condition was generally improving or deteriorating, rather than just focusing on one bad day. Okay, we've cleaned the data. Now, how do we turn this pile of numbers and codes into something meaningful for our model? This is feature engineering, basically, creating smart features that tell a clinical story. We calculated the Charlson Comorbidity Index. Think of this as a score summarizing a patient's overall burden of chronic diseases based on their diagnosis codes from the past year. More conditions, higher score, generally higher risk. We also added time-sensitive features. How long ago was their last hospital stay? How many times have they been admitted recently? How long did they stay this time? Crucially, we looked at medication adherence. Did they actually fill their prescriptions right after leaving the hospital? We calculated this ratio using pharmacy records. We also tracked trends in key lab values like creatinine and sodium over those T days before discharge, calculating the slope to see if they were improving or worsening. Plus, we included things like the main discharge diagnosis, how many different doctors they saw, and the total number of medications they left with. All these features were then scaled appropriately, so the model treats them fairly, using robust scaling which is less affected by those outliers we talked about earlier. Before jumping into modeling, we took a good hard look at the data itself. What did we find? First, remember that class imbalance? About 85% of patients weren't readmitted, and 15% were. This is pretty typical, but it means our models need to be careful not to just predict everyone is safe. We also noticed a slight seasonal trend. More readmissions seem to happen in winter, maybe related to flu season or colder weather effects. Then, we started digging into which features actually seem to distinguish between those who would be readmitted and those who wouldn't. Looking at box plots and density charts, two things jumped out: really high or really low sodium levels and having a history of frequent hospital stays. We also checked for multicollinearity, basically, if two features were telling the same story. For example, high blood pressure and high heart rate often go together. We made sure we weren't including redundant information. And importantly, we confirmed that clinical measurements do depend on previous measurements. Today's BP is likely related to yesterday's. This reinforced our decision to use methods that can handle this temporal aspect. Okay, time to pick our weapons. We evaluated 4 different types of machine learning models. First, logistic regression. This is like the classic detective, straightforward, easy to interpret, gives you coefficients showing how much each factor contributes. It's our baseline. Second, random forest. Think of this as a committee of many simple decision trees. It's great at handling complex, non-linear relationships and doesn't care too much about the scale of your input features. Plus, it has built-in ways to handle that class imbalance we talked about. Third, XGBoost. This is like a super-powered version of the committee idea using gradient boosting techniques. It's known for being really powerful, especially with imbalanced data, and we tuned it specifically for this task. Finally, LSTM networks. Long short-term memory networks are designed specifically for sequences like time series data. We fed it the daily clinical measurements leading up to discharge to see if explicitly modeling the time dependency would give us an edge. We chose these 4 to cover different strengths: interpretability, robustness, power, and explicit sequence modeling. How do we train these models without cheating? In time series problems, you absolutely cannot use future data to predict the past. So, we used a strict temporal train test split. We trained all models only on data from 2018to 2021 and then tested them only on the later data from 2022 to 2023. This ensures the model isn't peeking at the answers. Even within the training period, we used twofold temporal cross-validation. Imagine slicing the 2018to2021data into Wu consecutive chunks and rotating which chunk is held back for validation. This further protects against accidental data leakage. To get the best possible performance from each model, we performed hyperparameter tuning. This is like fine-tuning the knobs on each machine. We used Bayesian optimization, a smart search algorithm, to find the optimal settings for things like tree depth in random forest, learning rate in XGBoost, and sequence length for LSTM, running this optimization process eBay times for each model. Training itself used standard techniques like the atom optimizer with early stopping to prevent overfitting. Okay, the models are trained. How do we know if they're any good? We need metrics. The star player here is AROC, area under the receiver operating characteristic curve. Don't let the name scare you. Basically, it measures how well the model ranks patients. A score of Linggenwu means it's no better than random guessing, while Yidianling is perfect separation. It's great because it doesn't get thrown off by the fact that most patients aren't readmitted. But AROC isn't the whole story. In healthcare, missing a high-risk patient, a false negative, can be very costly. So we also looked closely at sensitivity, which is the percentage of actual readmitted patients correctly identified. We also checked precision, specificity, OPSI, and the FE score. But the really important question is, does this model actually help clinicians? That's where decision curve analysis comes in. DCA compares the net benefit of using our model against simpler approaches, like just using the Charlson Index, or a simple rule like flagging patients with SAN or more prior admissions. It calculates the real-world benefit, considering the potential downsides of both missing patients and overtreating low-risk ones. Remember we wanted a model doctors could trust? That means interpretability. We used two main tools. First, Shapley additive explanations. Think of SHAP as giving each feature a report card on how much it contributed, on average, to the final prediction across all patients. This gives us a global view. Which factors are generally most important? The results were fascinating. Number of prior admissions, sodium levels, time since last discharge, Charlson score, and heart rate variability ranked highest. Second, LIME, local interpretable model agnostic explanations. While SHAP gives the big picture, LIME zooms in on individual predictions. For a specific patient flagged as high risk, LIME creates a simplified explanation. Okay, for this patient, their low sodium and recent discharge date were the main reasons for the high score. We even built dashboards showing these local explanations to doctors. And crucially, we didn't just assume these explanations made sense. We showed them to 3 experienced physicians, who reviewed them and rated how clinically plausible they seemed. They gave high marks, averaging 4.3 out of 5. This validation is key for building trust. Building a powerful model isn't enough. We have to ask, is it fair? Does it treat different groups differently? We conducted a fairness audit. We split the patients into subgroups based on age, gender, and race, and then checked if the model's performance, specifically its true positive rate and false positive rate, was roughly equal across these groups. This is called the equalized odds criterion. We calculated ratios comparing these rates between subgroups. If the ratio got too large, meaning one group was significantly more likely to be falsely flagged or missed, we adjusted the model during training. We also checked if the predicted probabilities matched the actual outcomes for each subgroup, ensuring the model wasn't systematically over or underestimating risk for anyone. Beyond fairness, privacy is paramount. As mentioned, all personal health information was removed before analysis. The data was encrypted and only authorized researchers with proper approvals could access it. These steps ensure we're building a tool that's not only effective but also ethical. A brilliant model sitting on a shelf is useless. We needed to put this thing to work. The XGBoost model, which performed best, was packaged into a REST API. Think of it as a web service that other systems can easily talk to. We used Flask and Docker to make it portable and scalable. This API connects directly into the hospital's EHR system using standard medical data formats like HLT-FEAR. When a patient is discharged, the system automatically pulls their relevant data, sends it to the API, gets a risk score back, and if the score is above a certain threshold, say 0.35, which doctors determined was a good balance, it triggers an alert for the care team. But the world changes, and so does healthcare. Patient populations shift, treatments evolve. So we built in drift monitoring. Every week, the system checks if the incoming data looks significantly different from the data it was trained on. If it does, it automatically kicks off a retraining process. We also managed versions of the model, kept everything reproducible using containers, and logged everything so we can learn and improve continuously. So, the moment of truth. Which model actually did the best? On the final test set, XGBoost came out on top with an impressive ROC of 0.874. That means it's significantly better than random chance at ranking patients by risk. Random forest was strong at 0.841, logistic regression lagged behind at 0.792, and interestingly, the LSTM, despite being specifically designed for time series, scored 0.813. Why didn't the LSTM win? It suggests that the clever features we engineered, like the 7-day averages and trends, actually captured the most important temporal patterns effectively, making the explicit sequence modeling less necessary in this case. And XGBoost wasn't just lucky on the test set, its performance was rock solid across all 5 folds of our cross-validation, proving it's robust. This is a really strong result for XGBoost. A ROC is great, but remember, in this context, catching the patients who will be readmitted is critical. Let's look at sensitivity. XGBoost again led the pack with 0.831, meaning it successfully identified over 83% of the patients who were actually readmitted. This is fantastic news for clinicians trying to intervene early. Precision was lower, around 0.62, which makes sense given the low base rate of readmission. The OPS, which is a better metric than ROC when dealing with imbalanced data, also crowned XGBoost the winner with 0.718. But the real clincher is the decision curve analysis. This showed that XGBoost provided the highest net clinical benefit compared to existing tools like the Charlson Index or a simple rule based on prior admissions. Specifically, at a risk threshold of 0.35, which doctors found practical, XGBoost offered a net benefit of 0.128, significantly better than the alternatives. This proves the model isn't just statistically accurate, it actually translates into better, more efficient care decisions. So, what exactly is the model paying attention to? The SHAP analysis gave us the definitive list of the top predictors. Number 1. The number of prior admissions in the past year. This was the strongest signal, confirming what doctors already know. If someone keeps coming back, they're likely at higher risk. Number 2. Serum sodium level. This was surprisingly impactful. Both very low hyponatremia and very high hypernatremia levels were strongly linked to readmission. This highlights sodium as a key indicator often overlooked in simpler risk scores. Number 3. Time since last discharge. Being discharged recently naturally increases risk. Number 4. The Charlson Comorbidity Index, reflecting the overall burden of chronic illness. And number 5. The rolling standard deviation of heart rate in the days before discharge. This captures physiological instability. If your heart rate is bouncing around wildly, it's a red flag. These findings paint a picture of readmission risk as a combination of accumulated problems and recent instability. Does this model actually make sense to doctors? We showed them the LIME explanations for individual patients, and they agreed overwhelmingly. Doshirar% said the reasons provided by the model were clinically plausible. For instance, for a patient with heart failure and low sodium, the model correctly pointed to those factors as the main drivers of their high-risk score, aligning with what doctors expect. And the ethical checks? Good news there too. The fairness audit showed no significant bias against any demographic group. The ratios of sensitivity and specificity between age, gender, and race groups were all within acceptable limits, meaning the model treated everyone fairly. Calibration was also good across subgroups. Finally, putting it into practice worked. The deployed API handled thousands of predictions smoothly, detected minor shifts in data patterns, and automatically retrained itself, keeping performance high. This shows the system is not just theoretically sound but practically viable. So, wrapping it all up, we tackled the tricky problem of predicting Sancherde readmissions by building a machine learning system that truly understands the dynamic story told by EHRs over time. By carefully cleaning the data, creating smart features rooted in clinical knowledge, and rigorously testing our models, we built something that works. XGBoost emerged as the champion, offering high accuracy, good sensitivity, and demonstrable clinical benefit. Importantly, it highlighted key risk factors like prior admissions and, notably, sodium levels, which might not get as much attention in simpler tools. The fact that well-engineered features sometimes beat complex sequence models like LSTM is also a valuable insight. Critically, making the model interpretable wasn't just nice to have, it built trust and uncovered new clinical insights. This work shows that we can build smart, explainable AI tools that genuinely help doctors provide better, proactive care after patients leave the hospital.